Welcome, everyone. I'm just admitting everyone in from the waiting room. While we're waiting for everyone to load, please enter your name and agency in the chat, and then we'll turn it over to Tara to get started. We have a couple more. All right, it looks like we're mostly admitted here. Welcome to the January KPQC Learning Forum. I'm Tiffany Burrows, and I will be running the Zoom. We have Tara and Jill, and I'll turn it over to Tara to do introductions and get us started.
Hi, everybody. So happy 2023. I feel like I have 3 screens currently happening in my office, and I have no control over what's happening. So just so we're clear from the onset, thrilled to see you all. Really happy that you guys took time out of your Tuesday noon hour to meet with us. I have missed you all. We haven't seen you since October on the virtual platform, but certainly got to see many of you. And you see the picture in front of you of those that were able to join us at the general meeting, which we'll talk about here in a second. Today's Learning Forum is a quick review of 2022, a let's get going for 2023, and new additions to our family. In the classic birth setting, we have to make everything about labor, delivery, and postpartum, right? So I have a wonderful colleague of mine to introduce you to. This is Jill Nelson. You guys have seen and heard her voice before. She's been at KDHE for a while. She's been a trusted and respected colleague of mine for much longer, and a great friend of mine since literally we were born. So I know Jill well. That's a nice way of saying we just lost an important person in Casey Sorrell. She's doing great things with KFMC. And when that spot or that gap happened, Jill raised her hand. And so I could not be more excited and feel great about this next step for us versus that we're going backwards with the loss of Casey. That said, I'd like to start us off today by Jill introducing herself, telling you her role, which is, again, the replacement of Casey Sorrell, a great person and advocate. And then we'll take it from there. Jill?
Great. Thank you, Tara. Good afternoon, everyone. It is so nice to meet you all. I'm very excited to be part of this project. As Tara said, I've been with KDHE for the last 2 years as the perinatal and infant health consultant, and I'm thrilled to be working alongside Tara here with the KPQC and the 4th Trimester Initiative Project. So my new role, as you know, I was taking over for Casey, but my official title is the Maternal and Perinatal Initiatives Health Consultant, which is a lot to say. So I will just break it down a little bit and say that I oversee the Kansas Maternal Mortality Review Committee, and I am also I am the coordinator for the Kansas Perinatal Quality Collaborative. So I will be working closely with Tara and then also with our public health partners on the other side of the house to make sure we are linking both clinical and public health practices together. So excited to be here. Great. So, you know, we have a lot of acronyms and alphabet soup when it comes to all of these initiatives that we are a part of. And so just wanted to take this opportunity to kind of talk a little bit about the KPQC, which is the Kansas Perinatal Quality Collaborative. This is a group of leaders in our state who take a look at the data that we are receiving specifically from the Kansas Maternal Mortality Review Committee, and then making determinations at this point around what we're going to do about that. And so, of course, as you all know, we are working on the 4th Trimester Initiative, which was based off of those recommendations. And so I'd just like to take a minute to introduce all of these leaders to you. We have Dr. Kara Busenhart, who is our past chairperson. We have Dr. Nguyen, who is our new chairperson. It's nice to see you, Dr. Nguyen. We've been emailing. We have Jerry Harvey, Dr. Kimberly Swan, Dr. Kimberly Bray, Carrie Smith, Dr. Smith, Kristen Perez, Kirsten Green, Karen Brayman, and then Dr. Morgan as an ex officio, Dr. Bettinger as an ex officio, myself, and Tara as the lead QI coordinator, and then of course, Tiffany with the KFMC. So you have an amazing group of rockstar leaders who are helping to lead the way and to help guide the work. But of course, this is not possible without all of you and all of the hard work that you are doing in the community and on the ground. So I will turn it back over to Tara, but it's nice to meet you all, and I look forward to working with all of you in the future.
Thank you, Jill. As a reminder of all the pieces and all the parts, and again, we do this every January so that those that are new to the Kansas Perinatal Quality Collaborative, as well as those of us that have been around for a few years, there's several on this call that have been here since its inception, and you get a gold star by yourself. But a gentle reminder about, again, where we've been and where we're going. This is a pretty cool moment where I show you the state map. I tell you how many Kansas births are impacted by the work that all of you on this call affect. And we want that number to continue to climb. When I took over the role of the maternal QI coordinator several years ago, my goal was to be at 100% of Kansas births. And someday I feel like that's going to happen. I would love for it to be this year. With you all who are at these facilities, as well as those who are on the call that aren't enrolled quite yet, or in a community that's not enrolled with their hospital, reach out to us. We are excited to continue to add counties and hospitals to our initiative. But at this point, we are 30 strong in terms of birth sites, and 83% of Kansas births that are impacted by the first trimester project. This is just, again, a reminder of who all is, who has input or who is directionally serving us to do best practice outcomes at the immediate postpartum level throughout the state, and all the big hitters are there. Doesn't mean everybody is constantly at the meetings, which is good, but it certainly means that we reach out to these folks to find best practice models, intentional leadership, and certainly feedback in terms of decisions that are happening on the project. The next piece of our reminder was just 2 months ago. What did we do last year, after all, in our work to get postpartum care completely revamped? And that was a phenomenal moment that I got to be part of with you all at the general meeting in November. This is just my slide to remind myself how many of you were able to make that trip. 48 participants in total. We had our current and our our 2022 chair and our chair elect at that point both attended, and to hear their conversations at our table and directional recommendations that day based on these speakers that you see pictured in front of you was I should have had them mic'd up. You all would have enjoyed their hard work and brain work in terms of Kansas action. We did have 4 speakers, and I will tell you that I knew we had a great group of people to speak in front of those that were able to make it. I had no idea I would leave so inspired, and I was. And so if the person who knew who was coming was inspired, I hope that all 48 of you were. And for those of you who couldn't attend, I promise you that we will continue to provide great speakers at that same level to you. But there were laughs, there was frustration, there was amazement, there was learning, all the things that we want when we get together like that. 35 agencies and 16 4th trimester enrolled sites were in attendance that day. Another kind of recap. Again, you see that big group picture. We were missing a couple. This was at the very end of the day, but wanted to give everybody proof that certainly we made it, and we made it through the day. And if you're a chair or a chair elect, suddenly you have to be in the front on your knees. I'm sorry about that, ladies. I feel like the leadership should be standing. I realized that after the picture was taken. And Dr. Sandoval on the right-hand side, as a moment where she looks so serious, but she really made us think hard about one of the many topics that were covered that day, which was family planning. We also spent some really important deep dive time on site, both with colleagues that we knew. You see those folks from Topeka on the very right-hand side of the screen, talking and thinking about using words to describe our actions, actually. Again, you see the middle section, some folks from all over Kansas. In fact, I see Dana there and some others who's traveled a long distance to be with us and work on for trimester work. You see our chairs and somebody from our hometown who got an award we'll talk about in a minute. And then Tiffany. You guys don't understand how much work Tiffany does for you all. And that's her in the upper left. And I had to take a picture of all the things that she was in charge, physically and emotionally in charge of that day. And we need to thank Tiffany and her team from KFMC, because without them, we wouldn't run so smoothly on a day-to-day basis, as well as when we all meet in person. So there's caffeine. Please note that there's a lot of caffeine in front of Tiffany that day too. And a special thank you to you and your team. One of the things that I told you just now is that I left that day inspired, but also really tired mentally, because I know that we're getting there, but we're not there. And this slide that was presented by one of our speakers, I think I keep bringing up on my desktop as a reminder. And so I wanted to just bring it back up for those of you that were there and that weren't. When we talk about for trimester work and we talk about referrals and screenings and maternal mental health and post-birth and all the things, I have to remind you all, as the speaker did that day, that the impact of social determinants of health on our patients probably outweighs education at the bedside. So in other words, as much as we're doing work to improve bedside care in the postpartum setting, but also the discharge moment, you have to look at your patient as a whole, and you have to recognize what she brings to the table or the family brings to the table and address those needs. 20% of a person's health and well-being is related to their access to care and quality of services. If you look at that graphic on the left-hand side of the person, the stick figure, so to speak, and how each thing drives where they end up, sorry guys, but healthcare is 20% only. We're going to fix that 20%. That's where we are focused, is fixing that problem. But look at where we stand in terms of what really impacts her life. Pay attention to that when you talk to patients and you develop policy. Speaking of developing policy and making a big step forward, the Kansas Birth Equity Network had a big moment at our general meeting, and we are excited for our next steps with them, which we're going to deep dive into later today. They were wonderful to award many of our sites that had started or completed training, the KBEN training that were there, and also had a wonderful bidirectional presentation from the patient perspective, as well as the Birth Equity Network's leadership, and really liked the conversations that happened that day surrounding birth equity. I asked a couple of our folks that were there to come on this morning or this afternoon and to tell us their few cents or their few words about their attendance at the general meeting. So Chelsea and Katie, I think you guys are both on. I think I saw both of your names. Can you give us just a few minutes each of what your takeaways were and some food for thought that you went home on? Katie, let's let you jump on first if you're on there.
Can you hear me? Can you hear me?
We can. Go for it.
Okay. I think the biggest takeaway is, and I thought you were going to let me know this for sure, that I was going to do this, so I'm not as prepared as I thought it would be. But I think what I gathered out of the thing is that a lot of times as OB nurses, and especially I'm older now and I've taken care of young women for a long time, I think that I feel like, oh, they're, a lot of nurses will think, oh, they're healthy, they're fine, we don't need to worry about it, so their pressure is a little high or this is a little off. But in reality, there's people still dying in childbirth, and we just need to take it serious. And they're young, yes, but things can still go wrong. And so we need to be vigilant about vital signs, and not everybody's respiration's 18, like the woman said that day. I know you nurses do that. You just put 18. So I don't know, after that day, I looked at the other nurse I worked with and I said, yep, I think sometimes, we just kind of assume everything's going to be fine. And I guess we all know what assume means. So, and that was, the whole conference was good, but I think that's just a takeaway I kind of took from it.
Katie, thank you. You saw me cheering you on with the respirations are always 18 moment. I think that that's the thing that we can just be comfortable in this setting, virtually and in person, is the admission of guilt.
Yes.
Right? I would tell you, all,
Absolutely.
you bet. And our respiration is always 18, no, but also is charting the most important? No. Right.
No.
So there's some capture of normalcy in there. I also think that, and Chelsea, I'm going to have you jump in here. One of the things that was helpful is I looked around the room and saw everybody thinking, which means that we're all willing to be flexible and change process and QI, because we know that what's always happened wasn't good enough. Right. And I like that you speak to that, Katie. Chelsea, are you on and can give us your input?
I am. So I think one of the questions you had was kind of our favorite part. And I think one of my favorite parts of general meetings and just is getting to be in person and really getting those networking opportunities, talking with other leaders, seeing what challenges they're having, what goals they're working on, what's been working well for them, and just having that opportunity to do so. Kind of like Katie, I really like that hypertensive crisis and the LARC. With hypertensive crisis, we've established our policy and protocol in OB, but I think it really brought to light, I really need to focus more on extending that to the ER friends as well. And then just looking into maybe implementing that LARC here as well. And then the 2023 goals is that working with the ER and that maternal hypertension and the maternal mental health. We really don't have a policy for that, and so creating that policy and working on the networking. I think we do a lot of the things, but we don't have the policy in place to back it. And we have this problem. They screen positive. Now, what are we going to do for these referrals, and work with the clinic on that, and really establishing to hit that home prenatally if we can. That's what we're working on.
Chelsea or Katie, conversation of family planning. At the onset of a 4th trimester initiative, when you hear or think that we're going to talk about family planning, were you all surprised at how much or how little is happening in Kansas at the immediate postpartum setting around birth control conversation or family planning? Is it surprising to you at all?
Yeah, I mean, I think we have that conversation, but that's something where we didn't really have that in place to do that immediate postpartum. So looking at how to do that and looking with billing and coding and how we can make that be reimbursable to make that happen.
I think out here, I only know a couple of doctors that maybe would be interested in doing immediate at postpartum. We also have a couple Catholic doctors that don't really believe in birth control at all. So it's going to be something that is going to kind of tread lightly when we talk about it. And so, but I do think it's important, and I do think it's something we need to address here.
Yeah, again, each community, each setting, each provider, each group, each patient population requires a completely different algorithm, you guys, and that's okay to say. This is a comfortable place to say it's not as easy as an algorithm, Tara. So I just would say to you, family planning, you'll see is on our radar for 2023 some more with outreach and support to have conversation about interconception planning. So in other words, before she leaves the hospital, what's her plan and how can we help her in extending our hand of support? So thank you to you too. I always love to hear your voices and all of you that were there. I wanted to spend more time with you. So I look forward to that this next year. Speaking of some rock stars, we did take some time at the general meeting to recognize our 4th trimester sites. We decided actually almost at the onset of the 4th trimester initiative that we needed to provide a carrot to you all. Remember when it was COVID, as if it's not right now, but and I just needed you all to stay engaged because you were so busy and so pulled in directions, and I knew you needed to know that you were progressing forward. So finally, 2 years later, we came up with a system that we think is helpful so that you all know not only are you doing great work, but where are you in the process of becoming a full, what we'll call a gold star site, and silver and bronze. So what qualifies as a full meal deal, so to speak, and and everybody who is in progress and making steps forward. I'm not going to bore you with this slide. Just know that there were specific qualifiers that we used to achieve who's gold, who's silver, and who's bronze. Think Olympics. It literally was the Olympics when I was thinking about these titles. And so I just carried that forward because I'm a competitor. You all know that. And just know that when we awarded those bronze, silver, and gold levels to all of our 4-trimester hospitals, we wanted to make sure that of the programs that were within 4-trimester, 1 to 2 of them qualified you for, of the 5 qualified you for bronze, 3 to 4 of the programs being achieved was silver, and 5 of 5 was gold. We didn't expect anybody to be gold, and that's okay. I'll go back. Those that are 1, 2, 3, 4, 5, you will see more than 5 highlighted, but the 5 that qualified are not all of the projects that are embedded, as you can tell, in 4-trimester, but we pulled the 5 that we use the most. And again, you'll see that in subsequent slides if you have a question. This is the really crappy, not pretty Terra Strata version of where each facility fits now in that recognition level. So excited for you all, proud of you all. And excited to see who we can get elevated to the next level in this next year. This is or will be on our website in a prettier fashion. And again, you'll see this on the slides that we send out later. We would like for your hospital, your birth site, to know which level you are and to get a prideful moment. Many of you got your certificates of your recognition to go home with. Please use that as a marketing opportunity to tell your community how wonderful you're doing in this project. So that's wonderful, Tara, but now what, right? What do you got for us in 2023? Well, I'm going to rehash a few things that are a little uncomfortable. I like to challenge you all with some food for thought about why it is we're doing this work so that you all can leave with you heard Chelsea say, your 2023 goals. Quite frankly, we have a lot of work to do. We're making headway, but COVID and some other moments have set us back. So what do we know about our families? We know from the data back in 2020 that 57% of births have a medical risk factor. That means that 50% of our patients come to their birth setting with a medical risk factor, which potentially could lead to an adverse outcome. Now, it doesn't take a math wizard to figure out that 57% is not only more than half, but we're starting to get on the uncomfortable version of the majority. Many of those things we can improve. Alcohol use, for example, smoking during pregnancy, etc. But some of those we can't. So there are pieces of this that we can fix. There are pieces of this we can't, but you all need to know that if you feel like our patients are sometimes more complicated in the birth setting, you were correct. They are. What does that mean? Right? What that means is that when we start to pull the data in, and KDHE epidemiologists who are phenomenal, men and women who dissect the data from various groups, listen to our KMMRC, our Maternal Mortality Review Committee, dissect those charts some more, we come up with information that folks like you all at the KPQC level, and certainly in our birth settings, need to know. I'm going to highlight a couple. I will tell you that the final reports are coming out in February, and you will see them on our website as well as many websites. Sometimes it's too much information because we have a lot to share, but I'm going to highlight some of these pieces, and we're going to come back to it and be more specific about your communities and your birth settings in March. This slide specifically talks to severe maternal morbidity. If you recall, as you onboarded onto 4-trimester, we decided to focus in on the immediately postpartum setting through the first year because data proved that maternal deaths were occurring more in that time period versus in pregnancy or at the time of birth. Having said that, we can't just focus in on maternal deaths. We can't just focus in on pregnancy care. We have to look at the near misses. And SMM, severe maternal morbidity in Kansas, is addressed in these slides. Again, these are teasers. We're going to dissect them some more. What I wanted to pull out on the left-hand side, which is county specific, lots of colors, lots of information. But what you need to see and read is that the highest rate of adverse outcomes happened in counties and cohorts of women with the lowest income. That may be 0% surprise to you all, But keep in mind that that means lots of things. And that speaks to social determinants of health again. What can we fix? What can we do? What can we do to extend our hand to help? County specific information coming to you soon. Right-hand side is the conversation of the top 5 most common indicators of severe maternal morbidity in Kansas: DIC, renal failure, respiratory distress syndrome, sepsis, hysterectomy. Now, just by me saying those 5 things, anybody that works in the birth setting stops breathing for them for a second or feels tense. You know that if you're in any of those scenarios, that it's an extraordinarily hard day. And our goal is to prevent that moment. And if that moment occurs, take care of what happens next, right? So our focus again is on the prevention, the treatment, and the next step for all of these women who we take care of in Kansas. When we talk about the maternal deaths, when we talk about what are the causes, what are the disparities that are obvious, a lot of these things we're seeing again in reports, which again hones in our focus. The underlying causes of death in Kansas, the leading ones were again MVAs, cardiovascular events, homicide, and embolism. When we talk about the numbers, again, this is a range of years. This is a 5-year range, and that's important to keep in mind. If you look at the top left graphic, this should be alarming to you. And what it says, and the very last sentence was what hit me in the head. The translation of maternal morbidities in Kansas means that that 1 in 161 women who delivered a baby in Kansas experienced a severe maternal morbidity. Okay. So if we talk about it, 1 in 161 women, I don't care if you're at a small facility or a large facility, that strikes you as a tremendously high number. And then if you look at the causes of death and how wide range those are. And then if you look at the top right and it talks about the disparities, non-white minority women were nearly twice as likely to die within a year of pregnancy as non-Hispanic white women. Not okay. So again, I'm feeding you with some tidbits. We're going to hone in on this, but when we talk about what we're going to do in 2023, you need to know it's based on data specific for Kansas and the aha moments that are uncomfortable, but have to be addressed. Our number one call to action that came out of the data, once again, in this 5-year range of vital statistics and information from our families, says that one of the key recommendations that we must screen, provide intervention, and referrals for those things listed on the top left in the bullet points. They may look very familiar to you because that, in fact, is the majority of the 4 trimester work. The uncomfortable part is to the right where I've set the arrows there. Of the 103 contributing factors related to maternal death and morbidities in Kansas, this is the bad part. Facilities and systems level problems contributed significantly, right, to pregnancy-related deaths in Kansas. That's us. So if we can bring those numbers down and work on the other 3, patient, family, provider, and community, imagine the improvement of outcomes we could see in our state. But we have to focus in on our facility level problems, the system and what part we play in that system for patients, as well as pay attention to the other pieces and work on them. But that's why we're doing what we're doing. So what have you guys done? What have you accomplished in 2022, and quite frankly, since 2020? Deep dives. That's a picture out from Hayes when you guys sat around and figured out, okay, here's where we are and here's where we're ready to go next. You created vision statements, not just in Hayes, but across the state. I know you did, that talked about, okay, where are we and what are the gaps that we have in our community and in our facility. What I know you've accomplished is listed there in the bullet points. I know that you're figuring out how to educate women in post-birth and how to give those magnets out. When do we fill out the mom cards? How does that work to connect a mom to all of her appointments, but also to communicate amongst providers in terms of her birth and her follow-up for her and her infant? What do we do with birth equity? Now we know there's a problem. How do we fix it? Mental health screening, everybody, every single facility now that's a 4th trimester site has directional free TA to screen, to refer, and to figure out the gaps. The other pieces coming along, referral upon discharge. Who does she need to see? Who's your postpartum care team based on her individual needs? Where are you on your breastfeeding success rates and your next steps or gaps, including discharge home? Because we both know that, or we all know that when a patient and her family and her baby get home, those next 72 hours for breastfeeding are extremely vital, extremely vital. Postpartum visit scheduling, and then of course, updating your policies to connect to the revamp of the postpartum model. To date, we've trained 891 people in post-birth, and those are all 4th trimester related trainings. 18 sites are now onboarding or now educate all their onboarding staff. That's awesome. That's a massive change in 2022, meaning any new staff is trained in post-birth. 13 sites now have it as a standard part of their discharge education, which is, again, tremendous success and progress. In terms of maternal mental health, in this last year, 70 providers representing 26 sites have attended at least one training. There have been 29 direct TA sessions with KCC team and 4th trimester folks. We know that there were 9 sites in the original cohort that worked directionally on improving maternal mental health, but now 6 additional have taken us up on our everyone's in opportunities. And 10 sites have now overhauled their discharge policy in terms of screening and referral for maternal mental health needs. 57% of Kansas postpartum women now have a discharge appointment prior to discharge. That is awesome. I'll take that 57% because I want it to be 100, but I know each of us is making progress, and that is up a lot in those last couple of years since we started bringing that key piece of follow-up up. And then postpartum care teams are mentioned there. Again, most of you have a fully functioning postpartum care team, and that's wonderful. Birth equity, we're making progress. Again, we're going to continue to make progress so that we know that all of you are trained, but to date, 19 of our champions have been fully trained on birth equity, and there have been 61 who participated in some type of training this last year. 83% of our sites are either high five or baby friendly designated. That's awesome. If you are not in that group, it's very easy to onboard you, and I'm excited to work with the high five and KBC group again this next year. And 19 sites have a fully functional community resource list ready for anything that a postpartum mom could need. So 26,000 women and families in Kansas are impacted by just those progress pieces. Don't forget, we launched a new website. It's updated. It still needs updated. If there's something that you want that you can't get to as a site or an agency and you have some ideas, send them my way. That's a wonderful resource and clearinghouse for lots of information related to 4th trimester and the KPQC in general. And then, of course, a massive good news story for this last year, of course, was the Medicaid coverage to 12 months postpartum. By itself, this probably will change the most outcomes, along with our help to continue to help women access care. But the fact that they have Medicaid coverage goes back to that conversation of lowest income with more negative outcomes. We need Medicaid patients to access and continue care, and this is one step in that direction. So where are we now? In 2022, this is what we did. We knew that we were screening for these things: maternal mental health, medical risk factors, breastfeeding, and whatever it is that she told us she needed at the bedside. We educated on post-birth, the importance of that postpartum visit and community resources. We made sure she had a postpartum care team, and we worked on getting her postpartum appointments made with her OB provider, a breastfeeding clinic or advocate, mental health. And here's where we're going next: the standardization of that workflow. Workflow is a crappy word for saying a standard model, the new postpartum model, where everybody in Kansas, no matter if she's live birth, stillbirth, no matter why or how, immediately postpartum, she receives standardized screening, standardized referral, a team approach. She gets into the resources she needs in her community and gets that comprehensive postpartum visit made. It is a large scale model, but it is seeing success in our state. When we talk about more specific project success, there was an aha moment for all of us this last year with birth equity. It wasn't sometimes a comfortable aha. Sometimes it was a, ooh, I did not like that moment. I am part of the problem in Kansas. And all of us that took the training through KBEN had a moment of, uh-oh, not good. One of the things that we benefited from the training from our Birth Equity Network friends was this wonderful infographic, which is the conversation of stop, look, listen, and think. Without going through this because of time today, I will tell you that if there's nothing else that you have taken from KBEN training, and for those of you that we can't wait to onboard, this model of thinking is a phenomenal thing. Every time you enter a patient room, every time you have a patient interaction, and the questions you ask yourself before you speak or before you act, or as you listen and think, is probably one of my biggest aha moments of 2022. And I hope it was for you as well. I was challenged leaving the general meeting to allow you all to think about what our birth equity slogan should be for the first trimester work. I liked that idea a lot. I like even more that we would perhaps use that on-site intensive work that we did in groups to perhaps do at your facilities or to do in your agencies or even just to do yourself. We were tasked with creating some type of a birth equity slogan surrounding an acronym. And these are 4 examples of wonderful, wonderful acronyms that came out, and the creativity of you all was very, very loud that day, and your interest in really attacking equity in every birth setting. Again, I want to spend time going through these, but you're going to get the slide deck. This is slide 31. Write that down. I want you all to come back to this slide and take a look at what your colleagues have created and really think about what is your birth equity slogan in your facility or in your personal care of patients, and post it in your room, post it at your desk, post it on your phone, and use that in this next year. That was a wonderful experience in a group setting. We talked about the postpartum care team. We talked about the mom card, and I hope that you all have gotten plenty of them and magnets. I know that we just got another big task order for those accomplished, but keep me posted if you need access to print them yourself, or if you need anything in terms of the maggots or the mom card. Magnets, not maggots. I'm not sending you maggots. Magnets or the mom card in this next year. So where are we going together as a group? Before I open this up to a conversation and question, I want to tell you where my role feels like I need to lead you. We've got, again, a great leadership team in our executive committee. We've got phenomenal agencies engaged. We've got great 4 trimester sites. We've got data people. We've got all the people and more coming to help us. But where do we go next? I think that we focus in on finalizing that post-birth policy so that we know across the state, every patient is educated, every family member and community member knows red light, yellow light. What does it mean if she complains or reports or has symptoms of, and where do we get her next? Life-changing post-birth policies have to happen across the state. We have to deep dive into family planning, screening, and referral. Certainly, we just talked about that with our sites. Intensive work, we owe you our time, and I'm going to tell you how we're going to do that here in a few minutes, but intensive work with you all. Navigation services so that each bedside nurse or provider isn't responsible for all of the next steps, but can loop around with community resources so that the patient has a warm handoff. Attacking social determinants of health in terms of that navigation and work. And the ER. Chelsea mentioned this, but it is extremely important that each of you connects with your ER to connect with algorithms and process improvement. We know that that's where patients end up, and we want to prevent the morbidity and mortality moment. This workflow is now going to become the standardized postpartum model in Kansas. It is a policy, it's a procedure, it's a goal, it's all those things combined. Print that sucker off, figure out how it works in your community, and that's going to be our work intensively with each of our sites this year. Because a lot of our hospitals asked what screening requires immediate response and what screening requires, okay, let's follow up on the outpatient side. We created this, which is just what requires emergent and non-emergent response. Again, I'm just telling you what resources are there. I'm also telling you that we are going to connect you specifically in each community, starting with these 9, with outpatient navigation for your patients in the form of home visiting nurses, community health workers, OB navigators, folks that are in your community to help these patients so that you don't have to do it all. So virtual introductions are going to start with these 9 communities. We're going to connect the 4th trimester champion and anyone that you believe needs to be part of that conversation and meeting with your local navigator, community health worker, home visitor, agencies that can connect her discharge visit and needs, her screening, so to speak, with her outpatient follow-up. And that way we know that the patient and the gaps get taken care of. I look forward to those emails coming soon to those 9, and then we'll work through the state after that. Then also coming up is some very specific education in our learning forums, as well as in direct TA. Wonderful, though hard to talk about topic is coming up just next month in our learning forum. And I want to stop and let our KCC crew jump on and talk about this and their portion of our next year.
Thank you, Tara. So this is something that we have heard from a lot of providers is very necessary as we engage more in talking about substance use screening and referrals. This is mandated reporting is a really, really difficult subject to talk about. So our efforts here have been with KCSL, who do the mandated reporter training in the state, and DCF. This presentation will be co-facilitated by DCF representative and KCSL. And we're really trying to focus this training in on both what your role is as a supporter when you discover that a pregnant or postpartum mom is using substances, and what happens a little bit in the workflow of DCF to understand really how that case moves through the system. We're hoping to really emphasize some transparency here so that you all can have a better understanding of how DCF handles these cases. And they will also discuss what is and is not reportable in the state of Kansas, just for clarity. There's also a workflow that KDHE and DCF have worked really hard to develop. It's kind of a workflow for triaging pregnant women using substances when you are doing your screenings, and discusses family support services and other things like that that are meant to prevent that family from entering any kind of removal situation. So we're really excited about this. It's been a few months we've been working on this, and we're very excited to bring this to you all. We will also be doing a follow-up TA workshop a couple of weeks later. You'll all receive the invitation for that. That's going to be a time for us to come together. We have some experts from the KCC clinical team who will be joining that. And we really encourage you to bring your social workers along to both of these if possible, because we recognize that they play a huge role in this process within the inpatient setting as well. And that will be DCF and KCSL will not be at the TA workshop. They will be, this will just be us time for a very open conversation about what this looks like when you're thinking about forming policies, implementing universal substance use disorder screening, and really making those connections to community referrals. So we hope to see you all there. The training link is on the next slide, and we'll also post that in the chat now, and we'll post that in the chat during the Learning Forum next month.
Thank you, Jennifer. And sorry, I was navigating slides poorly today, but again, KCC is hitting the ground running. You all, if you have worked with them already, you know that they are a phenomenal resource for where are we at our hospital with evaluating maternal mental health prior to discharge, and what can we do to fill gaps so that every patient leaves with a plan if she needs one. The next piece that we'll touch on real briefly, and then you're going to hear more about this in the coming months from us, actually in the coming month from us, is that we're ready to collect data a more succinct and hopefully easier way than the Microsoft Word documents that I've sent you for the last 2 years. It's now all going to be in a centralized data collection place called QHI. Many of you have already onboarded your documentation and paperwork for QHI input of data. Our goal is that you would use something like an Epic or a Cerner product as your EHR to be trained by our team at KFMC to grab the data that's needed, upload it into QHI, boom, easy. That is the Terra Strata goal. So what we're working on right now is we're going to have you all submit it on a QHI platform online. Then it comes to me, and then I put it in the National Data Center, and you all get credit for all your hard work. Okay, so this is the list of the folks that have completed their QHI documents. If you do not see your name listed there for your facility as a champion, please reach out to Stuart Moore or myself very soon to make sure that we can get those documents done so that you can begin to submit data as necessary. And again, as streamlined and easy as possible. But before you do, these are the 4 wonderfully generous folks who are going to be our trial set. These 4 champions have agreed to trial and error the QHI input, make sure that it's easy to understand, it's easy to get data, and that you're not going to spend a whole bunch of time submitting data to us, because it's important, but it isn't the most important work. And so once we get this trial of 4 folks to kind of work out the kinks, then we'll bring it to the entire 4-trimester cohort, show you how to upload data into that system, and it becomes a streamlined process pretty quick. So we're excited about and appreciate those 4, and stay tuned so that everybody else can feel better about no more Microsoft Word documents. Then you all were wonderful to provide me specific feedback. Birth numbers, I got 23 of the 30 reporting back to us. Excited to get the other 7. That's reportable data that we have to submit at the state and the national level, you guys. And so those of you that haven't submitted your birth numbers, I'll ask you specifically so we can make sure that that's accurate. We use that in many settings, both live and still birth numbers. For our reporting purposes. And then the second question that one of the questions and second that I mentioned here is, of the champions that responded, we asked, okay, how would you like to increase your progress within the 4th trimester initiative? And the majority of you said more direct work with our leadership team on specific programs, as well as opportunities to meet with other sites who are facing the same questions. We hear you, we agree, and we will certainly set those up in the coming year. You also said, champions that responded, would you like to have several learning forums next year dedicated to just champion collaboration? And the majority of you said yes. So we're going to take that back to the leadership team and say, okay, how can we be very directional about our work with these sites so that they get their own time to make forward progress happen faster and more efficiently for them? And we'll come back with a plan of attack on that. And then this right-hand side graph tells us what programs you all said within the 4th trimester group would you like to focus on in the next year. And you can see maternal mental health and the discharge appointment were the 1 and 2 most important programs that you felt like you needed work on. I'm thrilled about that. Not that I don't see the rest of them. I agree that all of them require attention from all of us, but I agree that those are probably the two most important and life-altering programs within our initiative. I put up a common Q&A slide. We've got about 9 minutes left before I'm going to let you all go. This is the only time this year I hope you hear Tara Schroeder's voice as a majority. I don't like that you hear only my voice, but I wanted to update you all and to tell you the input and output that's coming up 2023. But there were lots of questions that come in on a frequent basis to me, and I wanted to make sure that I opened it up for just a few minutes. If you have questions, if you have recommendations, certainly jump on your mic right now, and we'd love to hear it. These are the things that I want you all to know we have answers for. Where do I find X, Y, and Z on the website? Or who makes up the staff, which Jill talked to you about that earlier. Where are those post-birth resources you talk about all the time on the website? And how do we train on KBIN? You know, over and over again, I get these great questions and I want to make sure they're answered. So I hope that you get those answers. But other questions, open it up for a few minutes for those. Just jump on the mic for me. I knew you all would be quiet. I knew it. So I tell you what, if you have questions, do not hesitate to reach out to Jill or myself, to Tiffany. Make sure you throw her some caffeine when you do. And don't ever feel like we are not a phone call or an email away. We want you all to have our support. And that's the number one message I wanted to get across today. So with just a few minutes to give back to you all, here is our next date and time of our next learning forum for KPQC. Again, assume that it's the entire elective and the entire cohort. Invite your colleagues, bring around some agencies that may be interested in this work. That learning forum is targeted on mandated reporting and supporting, because we know it's a hot topic in Kansas. We know there's lots of questions about who and how do you report and what happens next. And so as difficult as that conversation is, I'm thrilled that we get to talk about that and help you all with those questions next month. If there's no further questions, I will see you all in February. Thank you so much for your time today.